The meeting has been very exciting. I think there are a number of themes that you've heard, and that's the way I like to look at things. One of the drugs that we heard about from the plenary session is a new drug for breast cancer in women with HER2-positive breast cancer. A new agent, an antibody directed at HER2, coupled to a toxin. So, of course, the development of any agent for women who with refractory breast cancer is good news, because we have another agent in the armamentarium. But I think there's another theme, and that is that this is a class of agents. So, hooking a monoclonal antibody to a toxin, so you deliver the toxin directly to the cancer cell. And here we have the opportunity, sort of a targeted therapy, smart bomb therapy, if you will, and in an effort to sort of minimize the collateral damage that you do to other cells. We now know that it works in a solid tumor, which is the good news. We had evidence from previous years that this would work in hematologic malignancies like leukemia and lymphoma, and I think that we now know that there are many others on the horizon with this same technology of an antibody delivering a toxic agent directly to the cancer cells. So that's one important finding from the other day. Another important theme is really newer agents that help us with the side effects of treatment and diminish the quality of life for patients. Agents that have an effect on delayed emesis or delayed nausea and vomiting. So we have a new drug, or a drug that is actually an old drug, but a new indication that works very well. And an additional drug to deal with the peripheral neuropathy, which is a painful condition that results from some of the drugs that we use for women with breast cancer and other diseases. Again, a troubling side effect which limits our ability to give treatment, and this is a drug that helps with that side effect. My own favorite, of course, as a pediatric oncologist, is that we're learning about how the targets that we are developing new agents for actually are operative in multiple different tumors that are not necessarily related to one another. The targets don't understand that they're in lung cancer or that they're in a lymphoma. And so what we found is that a drug that was approved last summer for use in lung cancer, the drug crizotinib, which targets the ALK gene, it's produced dramatic results in patients with lung cancer. What we sort of should have known, we knew that this ALK molecule was a driver in non-Hodgkin's lymphoma, where it was first discovered. And so it's not surprising that the inhibitor, crizotinib, works terrifically in anaplastic large cell lymphoma, and the results that we're seeing in children with this disease are nothing short of phenomenal. And it may even work better in this lymphoma than it works in the lung cancer. Ironically, it also works in another pediatric cancer called neuroblastoma. There's a subset of patients who have this same ALK mutation driving their tumor, or ALK molecule driving their tumor, and this drug has produced some fairly spectacular results in some patients who have that as a driver. So another very interesting finding, and of course this molecule is now being found to drive a very rare sarcoma, inflammatory myofibroblast tumor, and also inflammatory breast cancer. So it may have broad uses. So our worry was that when we develop a targeted agent that's useful in only a very small proportion of the patients, we worry, is that going to be worth it for industry to develop these drugs? Instead, what we're finding out, you develop it for one indication and it's useful for multiple drugs. So this sort of gives us hope that this will be the new paradigm for the future. So that's, I think, one of the more exciting aspects of the meeting, not only for pediatricians but for all of us.